All right, I want to welcome to the stage a man who is really unbelievable, and I've been talking to him backstage. He's great. His name is Dr. John J. Wernert. He began the full-time medical practice of psychiatry in 1989. He obtained his MD degree from the University of Louisville School of Medicine in 1985, or as they call it, Louisville. His postdoctorate training included an internship and residency at the Indiana University School of Medicine. Through the Department of Psychiatry, Dr. Wernert has practiced in Central Indiana since 1989 and is licensed in Kentucky and Indiana. He is a clinical associate professor of psychiatry with the Indiana School of Medicine. Please welcome to the stage Dr. John J. Wernert.
Good morning, all. Of going from just kind of a general concept of where we are with health disparities, and obviously you've heard from the speakers about drilling down more specifically about where those disparities exist and how we might address them. But I want to pull you back a little bit and talk about something more global. From a public policy standpoint, what I do at the Family and Social Services Administration is run 6 large divisions of state government, and that includes OMPP, which is the Medicaid Office, Division of Mental Health, Division of Aging, Division of Disability and Rehab Services, Division of Family Resources. These are all the social benefit programs throughout the state. And so when we look at things, we look globally about how we can really impact these disparities. So what I want to pose to you is a question: can consumer-driven health plans truly address healthcare disparities? When the governor asked me to take this position about 1.5 years ago now, I was truly honored to do that, but I stumbled across a couple things right from the very start that were a little disconcerting. The first thing is, and you heard that I've been a psychiatrist for 25 plus years. My father was a psychiatrist, my mother was a psychiatric nurse. So I think I know about stigma, and stigma specifically with our patients with addictions and substance abuse, as well as mental health disorders. And we know that those individuals suffer mightily from stigma, but what I found when I came into state government is there's even a worse kind of stigma, and it's the idea that people who are at or near the poverty level or who have disabilities somehow don't care about their health, or they're not interested in the health of their children or their family members. And we know that's just not true. Everyone in this room knows that's not true. But what do we do about battling stigma? In the world of mental health, we've done that by changing the conversation and the understanding about mental illness, which is that these are brain-based diseases, really no different than treating diabetes or heart disease, and that we can make a real impact because we now have treatment available that can really change the course of outcome and improve people's quality of life and ability to function. So success is the best driver to reverse this stigma surrounding mental health, and I believe that we can do that as well when we talk about health disparities and those at or near the poverty level. The second thing that I kind of learned was that in the bureaucracy of state government, change oftentimes is a little difficult. This was kind of my first couple of meetings where just kind of the desire is, well, it's a pretty complex problem. Why don't we just pray or hope something magical happens instead of really digging down into kind of the messy work of changing public policy? So what I want to talk to you about today is really a different concept surrounding healthcare, which is consumerism in healthcare. Specifically, does it really matter who pays for healthcare? I believe it does. And managed consumerism is a kind of a new field, a new topic that you've heard some speakers at least reference, but I'd like to talk to you a little bit more about what that means. Why our Healthy Indiana plan has become the national model, I believe, not just for an alternative to traditional Medicaid, but how we can really put consumer-driven health plans into the hands of individuals who can make better choices about their care. So I'll tell you a little bit about how HIP works, and then it's really crucial that you understand that we've significantly increased provider reimbursement, which addresses the access part of that equation, and why that's different for this plan versus just traditional Medicaid expansion. And how does a plan like the Healthy Indiana plan truly address disparities? Just a quick definition, what is healthcare consumerism? It's really a movement which advocates patients' involvement in their own healthcare decisions. Many of you are in these type of situations with your health plans now, and I'll show you a little more data about that. But basically, this is moving from doctor says, patient does to a new kind of partnership with individuals. Now, I trained 30 years ago, come from a medical family. Doctors just typically love that. I'm going to tell you what's wrong and what you should do about it, and my expectation is that you're just going to go out and do that. And the fact is that, particularly with younger generations, the response typically is, well, thank you very much for your opinion, doctor, but I'm going to go check it out myself. And I'll check you out before I even come to see you by checking you out on social media, and then I'm going to look if your treatment plan or your recommendations to me really do make sense and whether I'm going to follow through. So it really involves transfer of knowledge to the patient. I remind my students all the time that doctor in Latin doesn't mean prescriber or diagnoser, it means teacher. And our job as physicians, as providers across the board, is to be an educator for our patients. And then, who pays for those services? We need to move from this incentivized third party, that intermediary, typically insurance companies, to the consumer having control over that. Now, I could talk for hours about some successful models of consumer-driven healthcare, but since I heard Dr. Adams is flying out of here this afternoon to go to Switzerland, I thought we'll just pick Switzerland as an example. They've had a kind of novel approach for the past 15 plus years about consumer-driven health plans. And in Switzerland, you have universal coverage, so no one is really uninsured in that country. And they have been able to demonstrate that they can get significantly better outcomes in infant mortality, in pediatric care, and geriatric outcomes with a significantly lower cost. We know that our GDP, or healthcare compared to GDP in our country is about 17 to 18%. Where there, it runs consistently around 10 to 11%. By the way, doctors and providers get paid pretty well in Switzerland. It's not like the Canadian system. Maybe they don't make quite as much as some of our specialists do, but they do quite well. But the important thing is that individuals are required to buy their own health insurance. And in Switzerland, about 20% of the population live near poverty levels that require almost 100% subsidy from the federal government to pay for their insurance. The key thing is the government gives them the money and they still go out and buy the insurance. Significantly different than what we have in our country. And what they found, and some of these numbers need to be refreshed, but in the first 8 to 10 years of the program, they were seeing that with health savings accounts, which is a component of their system, 85% of the enrollees carried a balance forward. And I'll show you some data from our HIP 1.0 program that shows very similar things. They saw an 8% increase in preventive care visits. So there were incentives built in to get people to go for their primary preventive care, and providing an opportunity for providers to begin to compete and open up those markets so they can freely design and price services so that individuals feel like they're getting a good value for the money because they start operating like consumers. And if you think that we here in the United States aren't in this situation, just look at the numbers from this Kaiser Foundation study, which was published in 2012, but it shows trends from 99 through 2012. And I know it's very difficult to see, but the bottom line is the overall inflation rate over that period of time. And then the next line up at 47% is where workers' earnings have gone over that period of time. What's staggering is the next line up, that green line, at 172%, is what's happened with the health insurance premiums during that period of time. And then the top line is the percentage that the individual employee pays for their contribution to their premiums. And the point is that even though the inflation rate hasn't gone up that much, workers' earnings haven't gone up much more than inflation, but the amount that they're responsible paying for their health care has gone up considerably over that period of time. So they're beginning to think and function like consumers rather than patients. There's some fundamental differences philosophically between being a patient and being a consumer, but I would propose to you that those things are merging in the field of healthcare so that we're seeing, for example, in terms of level of engagement and decisions about their treatment, a patient is kind of what I was taught was the way we should approach individuals when they come to us for care. A patient has a low level of engagement and depends on the physician or the caretaker to make decisions on their behalf. Me, doctor, you patient, here's what I recommend you do, and I expect that you're going to do it. versus a consumer that has a very high level of engagement in their decisions, and they depend on the physician for, once again, recommendations and education, but they're going to do what? They're going to go out and personally verify that that's good information, not just take your word on it. Older doctors don't necessarily like that, but that's the reality of the world today. What about level of awareness and treatment options with associated costs? Again, patients have very low level of awareness about other options or what things cost. They depend on the physician for that opinion. And that, unfortunately, is why many healthcare systems have gotten some trouble, and we have the Stark rules and things like that, where you can't self-refer to clinics or to radiology centers where you own an interest. A consumer, however, has a very high level of awareness about treatment options and costs. And where are they getting that information from, guys? You get it online. Heard the last speaker talk about the phones, but it's the fact that you can now, from prescriptions to the cost of surgeries, to the differences in costing at the various health systems in your local community or in your state, you can get that information and then check it out on social media. Thankfully, there's some good news for doctors. The source of trust in providers they use. Patients have a very high level. They base it on their personal experience and word of mouth. It's kind of a lot like Congress. Nobody really likes the work of Congress, but they love their congressman or congresswoman and re-elect them frequently. Same thing with doctors. We hate what's happening in healthcare, but boy, don't mess with my doctor. I love him. Same thing with consumers. They have a high level of trust, but it's based on their personal experience, but also on comparison shopping. They've checked you out before they come to see you. And the point is, in all these different categories, you see that as people were taught to be patients, they're now learning to become consumers, and what's driving that change for them is the fact that they're financially at risk or going to be required to make those decisions based on the fact that they have ownership in their health care. There are also some generational differences. Nothing here should surprise you. The top one, for example, would like to customize their health plan. The top line are the millennials and the younger generations. The older patients, less so. So not only do we see, as you're hearing today, differences in terms of race and level of income and community that you live in, but there are also generational differences in terms of, and no surprise, the younger generation is much more apt to want to utilize technology and leverage what they find out in online applications about cost and pricing of services and what they expect out of their providers. So what does it mean to be in a consumer-directed healthcare plan? Very simply, it's a high-deductible health plan backed up with a health savings account or a similar product to pay for those first dollars when you go for care. How many here are on that program like that? Anyone who works for the state is, right? So that's about right. And Indiana has a storied history of really being on the forefront of encouraging that type of consumer-directed health plan. When you started applying that to issues like what are we doing with the ACA and Medicaid expansion, you look for that sweet spot. These are relative poverty levels throughout the country, and you see those two red markings as where we're going with the populations at 100% of federal poverty or below, or 138%. And again, where does the marketplace and the ACA match up with the expansion of Medicaid for many states? Many of you have seen this slide. This was data that we used in our waiver application in the spring of 2014 to begin our efforts to expand our Healthy Indiana plan. And at that point, we were showing about a 13% uninsured rate in the state. But that blue area, that 348,000 people, was the sweet spot that we were going after. And I would submit to you that with the expansion of the Healthy Indiana plan, we have shot way past those numbers and are really impacting other areas on that chart. I don't want to become political about this, but the reality is the ACA is the law of the land. And there's been a couple of Supreme Court decisions, including the decision that you can't force states to expand Medicaid. The president also laid out a challenge a couple years ago. It said, states, bring me some alternatives. Show me plans that would work better in terms of putting patients in a position to make better choices and get better outcomes, particularly in Medicaid. And the enticement, of course, was that 100% federal match for the first 3 years, which is expiring quite soon. In a little over a year, January of 17, that begins to phase out. 28 states plus the district took the money and did pretty much a straight expansion. But it was our feeling, and the governor led the way on this discussion, that we really needed to do something different. And we had some data from our initial Healthy Indiana plan that was able to carry the day. Problems with traditional Medicaid, we all know this. It's an outdated model with low incentives for people to get healthy. What were our successes? We had an advantage when we proposed the Healthy Indiana Plan expansion in that we had, since 2008, the HIP 1.0 program. And what did we find with that? We had numerous years of data that showed, for example, when you were on the Healthy Indiana Plan, you had lower unnecessary emergency room visits, 7% per year. That's a significant difference. People were incentivized to go and get their primary care at their doctor's offices rather than in the emergency department. 60% of HIP members received preventive care. 80% of HIP members chose generic medications compared to 65% in commercial populations. So excellent results there. We also saw high member satisfaction. 96% of the enrollees were satisfied with their coverage. 83% preferred that design to an alternative, which was straight copays under Medicaid. And HIP promoted that issue of ownership and personal responsibility in that 93% of members make those required power account contributions on time. Again, functioning more like consumers. Because if you don't pay your premium to United or Anthem or Aetna, they may give you 1 month grace period, but after that, do they say, don't worry about it, just pay us when you're ready? No. You have to get that money to them, and it's the same thing under the Healthy Indiana Plan. It's promoting that ownership and responsibility to be able to demonstrate your commitment to the plan. I show this slide, and this I think is the fundamental difference for you to take away versus straight Medicaid expansion, which is that bottom bar, because Medicaid coverage is essential. And for many states, that may be the only vehicle for more folks getting coverage. But coverage without access to care or providers that are willing to see you is really not worth much more than the plastic that card is printed on. What we've addressed, I believe, is with access, you lead to health improvement, and that certainly works in populations in health disparities. I don't want to go into a lot of the structure because this is a TED Talk, but how is HIP 2.0 different? Again, we've expanded the power account contribution from $1,100 to $2,400 a year. That's what the state puts in. Pregnant women are exempt from all cost sharing in both plus and basic plans, and there's an incentive to get your primary care done. If you do that, then your contributions to the power account roll over to the next year. And we've seen good uptake in that. We also eliminated all the enrollment caps. We only had about 50, 60,000 people in HIP 1.0. 2.0, we can take as many Hoosiers as meets qualifications. The HIP Link plan, HIP Link is something we're really excited about that'll be rolling out soon, related to employer-sponsored insurance premiums, and then again, promoting good health and good outcomes. What you'll see here is that these are, since the governor announced in the end of January, went live February 1st, you've seen that as far as minority populations, a good 26% of all of our HIP Basic and Plus membership are in minority categories. And that's significant in that we're getting more coverage and more access for these individuals that are in disparity groups. And as you've seen, our initial enrollment numbers that we submitted to CMS would be that we were looking at the first 2 years about 340,000. We've already well passed that number. We've had over 460,000 applications completed, and we have over 340,000 people or 287,000 on this slide, but we're going to be well over 350 by the end of the year. And the red marking there, the red column, is the African American population. That's a significant part of the minority group. Medicaid enrollment for pregnant women, again, 65% are white and 35% minority at this point. The power account contributions are modest. Over 50% of patients, if your income is negligible, it's really $1 a month. Remember, with HIP Plus, you get vision and dental benefits, expanded surgical benefits, including bariatric surgery. these are meaningful additions to the benefit structure for Healthy Indiana Plan that folks can buy up to for a very minimal cost. So it's really not about how much they're paying, it's the fact that they are paying, and they'll need to continue to pay those to be able to buy up to the plus. That's the only option available between 100 and 138% of federal poverty. Below that, you have the HIP basic option. So I'm going to bypass these slides because I want to touch, as my time expires here, that under HIP basic, what is different is that instead of paying into the power account and having no cost sharing for procedures, for doctor visits, for medications, you'll still have that coverage, but you're now going to have copays associated with all those services. And this is new, this is different, because Medicaid recipients typically have not had copays related to their services. And this is where we make the value proposition. The first couple of months, we didn't see a big uptake in HIP Plus. Folks were saying, I'm used to not paying anything for this coverage, therefore I'm just going to go with the basic plan, until they get sick. And then they go to the primary care doctor and they say, yep, you've got bronchitis, and so that's a $4 copay for the doctor visit. And we need to get an x-ray, $4. And we have to get a CBC, that's $4. And then I want you on an antibiotic and antihistamine, $4. So people started to do the calculus, right? Well, that was 20 bucks for that visit versus paying $12 for the entire year of coverage for enhanced benefits and no cost sharing. That's when we started to see the numbers almost go logarithmic, and we're now seeing about almost an 80% uptake in HIP Plus, people paying into the program. Again, folks at or near the poverty level, functioning like consumers, making good choices about an expanded benefit for their health care. This is my last point. Doesn't work unless you start paying providers appropriately. We had not adjusted our Medicaid fee schedule in over 20 years. And it was very difficult to find physicians and clinics that were willing to take all these additional members. They loved the reimbursement rates under HIP 1.0 because those were Medicare rates versus Medicaid rates. That delta is about 30% across the board. And in addition, we said we can't just leave all those that are taking care of the traditional or our legacy Medicaid members without doing something there. So those populations also got a bump. And when the governor gets here in a little bit, you might thank him for that as well, because that took real leadership to step forward and say, we're going to do across the board Medicaid reimbursement increases for our providers. And behavioral health and maternity obviously were two areas that we gave extra funds for. These are significant when we talk to doctor groups about that. Your bread and butter office visit, new patient, and 99203 at M code, we were paying $47 before. Now under HIP, we pay $102.28. You look at your standard office visit, follow-up visit, 99213 went from $31 to $70. These are substantial increases and pumps significantly more resources into the system and enticing more providers into the network. And I'm pleased to tell you at this point, we've added 4,300 clinic and office sites. We've added well over 1,000 new providers, and many of them are primary care physicians who are now back in the game. It's also a sustainable program. You probably been following what happened this week with the election down in Kentucky. The Republican won there because he's promising to roll back Obamacare, as he called it. The reality is that he's already stepping back from that, because what's the alternative? Healthy Indiana Plan is a good alternative to that. Now, I'm not saying they're going to have the Healthy Kentucky Plan, but what we have here is that our hospitals have come forward to help us fund this going forward. And in addition, the dollar tobacco tax that was added back in 2007 is used first to pay for the state portion of this expansion. So we have a sustainable model. We're not going to be Illinois, or that's just going to abandon the program when it runs out of money and they have to pay in 2017, or other states like Kentucky that are looking at curtailing the program because they don't have the funds. Again, the rollout has gone very well. No crashing of the website. We moved 170,000 people right from the very start. We've had 460 applications. Enrollments past 340,000. People vote with their feet, and they have been highly embracing this program, including our presumptive eligibility program at clinics and hospitals, getting folks under coverage and doing a great job. So hopefully you've seen our advertising on the buses and the billboards. They're all over the state, and we've got new messages coming out to continue to drive folks to take a look at this program. So in summary, this type of consumer-driven health plan really is an alternative. It's the Indiana-specific solution. As the governor calls it, this isn't Medicaid expansion, it's Medicaid reform. And I think it very much is, because it's reflective of the times, and it's reflective of moving patients in a position that they can be good consumers and take ownership. And we could talk more about price transparency and the partnership, but I think the reality is we know coverage, number one, is the most important thing, but that doesn't necessarily lead to increased access, so the additional reimbursement has been key. The power count, even though it's complicated for some folks to understand, paying that at the point of sale, at the point of initial care, does require that patients start to pay attention to what things cost. No different than those that went downstairs to Starbucks. When you have a gift card and it's 20 bucks and you swipe that card and your cup of coffee was $3, now you got 17, similar to what we're going to have now with patients. They'll come in with a Healthy Indiana plan card. Once that gets swiped, eventually they'll be able to get almost like a receipt that'll say you had $2,400 in your account minus the $100 for today's visit. Now you have $2,300. Again, beginning the change in the mental process and the attitude. So again, expanding plans benefits minorities that were previously uninsured and underinsured. And again, we're improving health literacy by putting folks in a position to partner with their provider and get that education. We need your help. This education is difficult for many of our patient populations to understand. But again, as we saw with HIP 1.0, once they get on the plan and once they understand how it works, and that may take several months, then they begin to invest more actively. And we're already seeing, I can't report to you today, hard numbers, but substantial improvement in emergency room visits, substantial increases in preventive care and primary care visits. These are the type of things we're looking for that I think will really begin to make an input and have major impact for our patients going forward. So with that, I'm way over time, but Dr. Adams wants to grill me on some things, so thank you all very much.
Thank you.
And as those guys get ready to answer each other's questions, I just want to remind everyone to submit your questions, because they'll talk for a few minutes, and then we're going to be answering your questions with the entire panel on this stage. So without further ado, here is Dr. Adams and Dr. Wernert. Guys.
Well, thank you so much. That was a
pleasure.
wonderful job. And one of the things that I want to communicate to the audience is you've got your two health agency heads here, the head of Family and Social Services and the Indiana State Health Commissioner. And in other states, a lot of times there's a disconnect between those two groups, and the agency heads aren't approachable. But one thing that we're committed to is being available and working together. And I want to thank you for being here today and for all the efforts you've made to make sure our agencies are on the same page.
Thank you, my friend.
Now I'm going to grill you.
Okay, ready.
Well, you spoke about Medicaid and problems with Medicaid, but particularly as it relates to infant mortality, the biggest problem, in my opinion, with Medicaid is you're not going to take someone who's unhealthy as a woman and then magically they get pregnant and get on Medicaid and they're going to be healthy. And so states where you have to wait until you get pregnant to get on Medicaid, it's no wonder you're not seeing a change in outcomes once they get on Medicaid. Can you speak about the Healthy Indiana plan and how that helps potential at-risk, not only mothers, but mothers-to-be?
Two big areas. That's a great question. You know, the old Medicaid system, you had to be in special categories. As you're mentioning, you would have to, you know, you may not be eligible, and then you become pregnant, then you could be eligible, and then you stay on for a year, and then you go off because you're no longer eligible. We think the Healthy Indiana plan really addresses that, and that it's really income-based now. So our goal is to get as many folks as we can on the plan, where in the past there was enrollment caps. We could only put so many folks into the program. Now we want every Hoosier that's eligible to be on the program. And we've worked very hard to make sure that it's seamless for those individuals. So, and that includes families who have seen their families split up in terms of coverage under different health plans. Perfect example, someone might have been a MedWise on the MedWise plan, and then the baby's born and it gets auto-assigned to Anthem, and then someone else's, other kids are on MHS. Really, we've changed the assignment logic so that families can stay together and stay on the same health plan. And once a mother is on the plan, she's going to be able to stay on that plan, and she's going to be able to maintain her coverage because, again, she had HIP prior to getting pregnant, and she's going to have HIP after, and certainly after that 1 year period of time. So again, it's about her health as well, because remember, many of these, particularly younger moms, they're going to have other children, and now there's a real commitment to them, and they're seeing the benefit. We need to make it easier for them, and that's we've tried to address that. But it's also the fact that they can now start to make decisions about care for themselves and care for their children. And we also know that, you know, it's that postnatal care for the baby that's important as well, and we think this really addresses that.
Wonderful. You made a plea to the audience in one of your last slides. You said, we need your help. Can you speak to some of the challenges? Because it hasn't been all sunshine and lollipops with the HIP rollout. What are some of the challenges you faced, and what help do you need from this audience? Is it education about healthcare literacy? Is it actually getting people signed up? Is it more Spanish-speaking navigators? What are some of the things that the people in this audience can do to help you deal with the challenges that you're facing?
That's a great question, and those are some important areas that I think we've tried to address. But I think first and foremost, it's making that value proposition at the time someone is getting care. So, perfect example of a theoretical construct, and we built this into the Healthy Indiana plan. There's a $25 copay for an unnecessary emergency room visit. Now, there's inherent problems with that right from the very start, right? How do you know when you go in? Just because you ate 12 tacos and you have terrible gastritis, why couldn't that be a cardiac problem? So you can't really put that on the emergency department and say, because they have, by EMTALA rules, they have to evaluate the patient, determine, okay, it's just gastritis, it's not, you're not having a cardiac event. But the idea was, then you would go out and say to the patient, who now is greatly relieved that they're not having a heart attack, by the way, you have to pay $25, and you can't pay it out of your power account, you're going to have to come up with the cash. I'm not sure most emergency departments could take a cash payment, quite honestly. And so the whole system, the idea was that you've now come in for an unnecessary type of emergency room visit rather than going to your primary care doctor, but you're going to have to pay out of pocket. It needs to sting a little bit. That's been a problem because the hospitals, the emergency departments, and the ER doctors don't want to be put in a position where they're trying to collect. And so they send the patient a bill, and now we get into this whole issue of, well, are you really educating anyone now that the care has already been delivered? So where we really need everyone's help is that these discussions need to happen during a period of relative calm, like during those preventive care visits, where you sit down, take the extra few moments, and I'd say this to the doctors as well. You have to explain why it's in their best interest, both financially and from a healthcare standpoint, to make that investment in paying up to plus, or at the very least getting on to the plan, because all the clinics have navigators or access to navigators, and we can do presumptive eligibility. We've made it as simple as possible to get them on, but they still don't understand why they need to get on or why that's important, because many of you have just been providing the care in the past and not really made a big issue about what things cost or how that's going to impact them going forward. So that's the value proposition, and the fact that if you ask most clinics, when this EBT card really starts working, who doesn't love the idea that you can then swipe that card and the money comes right out of the power account into their checking account? It's definitely going to help cash flow and help clinics be able to say, we can financially sustain ourselves as we see more and more of these folks coming in with coverage.
Great. Well, Terry talked about poverty earlier, and one of the things one of the questions I asked her was about neonatal abstinence syndrome, which I don't think we talk about enough. But the tie-in, I think, to the Healthy Indiana plan is mental health parity. Can you talk about the concept of mental health parity and HIP as related to traditional Medicaid and other Medicaid programs, and how you think that can help us with the problem of neonatal abstinence syndrome?
Absolutely, wonderful question. You know, everyone focuses on the Wellstone-Domenici Act. That was the federal Mental Health Parity Act that was passed 6 years ago. It's taken 4 years for all the rules to be written, and then there's many plans that have been somewhat suspect in terms of, are they really following the spirit of the law? Remember, Indiana had a mental health and substance abuse parity law years before Domenici-Wellstone. So we have been a state that's modeled that for well over 12, 14 years. Just having parity of mental health benefits really only addresses copays and deductibles, and is there any financial disincentive on lifetime limits for individuals that are getting care. So the whole substance abuse piece gets very complicated because let's assume for a minute an individual who has an addiction gets on the Healthy Indiana plan. It's great to have that coverage, and we need to make sure that they have access to good providers and good care, but there's still that element that are they willing to commit to sobriety, not just because they're pregnant now, but are they going to be committed to sobriety after the baby comes and continue on in that programming. This is a huge issue because the expense of the neonatal syndromes and the drug addiction problems that we see in pregnancy are really just going to continue to multiply for systems, and we see these children who have significant developmental problems as a result going forward. Again, we feel strongly that if an individual feels and understands why they need to get on good coverage, that they'll do the things necessary if their provider is willing to work with them and not be judgmental about the fact that, yes, they have a drug addiction or a heroin addiction, and that this really is not just about taking better care of yourself for the life of the baby, but what are you going to do after the baby comes? I see it from a psychiatric standpoint more to the lack of nurturing and bonding that a mother will exhibit with the child, mainly because they immediately go back to their previous behaviors. And so it's really a commitment to not just sobriety, but to staying in treatment after the baby comes.
Great. One of the knocks that you and I get as physicians and that we get about the Healthy Indiana plan is we're too far downstream. We aren't doing enough to focus on preventing problems as much as treating problems. Can you talk about the Healthy Indiana plan and its contributions towards primary prevention and keeping people healthy as opposed to simply providing coverage for them when they get sick?
In addition to all the obvious kind of answers to that, it's, again, building the incentives in there. It was crucial, I think, that we put in the element that if you just go for your annual physical, and that's paid out of the insurance portion, so it doesn't come out of the power account. That means your annual physical, the lab work, mammogram, colonoscopies, that's all paid. And if you do that, and you explain to patients that whatever amount they're putting in terms of their monthly power account contributions will now roll over into the next year. Much like Switzerland, you're seeing that people, when they become good stewards of those funds, they like to see them roll forward. This doesn't cost them anything, and it incentivizes them to be able to keep their money in those accounts. So I don't mean to make it sound just about a financial decision, but again, once you engage people at that level and they start functioning and thinking more like a consumer, they'll make the right choice, and because everyone in this room is that way. We could say, we do this for the love of caring for patients and the peoples in our community, but you still need to get paid, and you still need to think about appropriate financial incentives will make a big difference in terms of people's behavior.
One more question, and it's a tough one, and don't beat me up for asking you this, but we talk a lot about smoking in pregnancy and the effect on prematurity, on bad outcomes, but Indiana Medicaid and Indiana HIP has a limit to the amount of medication it will dispense for tobacco cessation. Can you talk about that and why that is, and whether there's any plans to try to extend the amount of time people can get payment for smoking cessation drugs and services through FSSA?
I'm right on board with you there on that one. The Public Health Service just came out with some new guidelines about extending those coverages. And we have what's called a Drug Utilization Review Board, which is a federally mandated board that reviews these guidelines, and they've made strong recommendations to expand that. Like anything else, and this is somewhat unfortunate, Indiana runs on a biennial budget, so we get a budget approved for 2 years. If you try to change anything after that budget's approved that has a pretty high fiscal impact, and this is several $1 million more of state money to pay for these coverages, it becomes an issue because where are you going to get the money to pay for that? So we're strongly committed to going forward. We're going to make sure that that's included in our budget forecast going forward, make sure that we can continue to expand coverage for smoking cessation products. It's an absolute necessity.
Medicaid is a big payer, and we talked earlier about payment driving behavior. But what are you doing to engage the MCOs and to spur innovation by the fact that you're the payer in the MCOs who actually are in charge of delivering the care at really the grassroots level?
and this happens unfortunately in many states, where you just turn the dollars over on a per member per month basis to the MCO and just assume that they're doing good care management or care coordination. I was talking with some folks earlier today. The state has never really engaged at looking at these things retrospectively, looking at the claims that are submitted. Are the things that they're really doing impactful? Are they really making a difference in terms of outcomes and people's health? We're 100% committed to doing that. We have a huge data warehouse that we're not taking advantage of. And so we've already alerted the MCOs that we're watching, and our expectations are that they be flexible going forward, because there's some things they may be doing that we're requiring them to do that may be a little antiquated and aren't really giving us much bang for the buck. Our commitment is that we want to see good value for the dollars the taxpayers are investing in the Medicaid program. Obviously, with the expansion, a lot of that is federal money, but over time that's going to be less and less. And we certainly are not going to be a frivolous state and not make sure that patients and individuals are getting the best care they can for the dollars that we're spending. So we're going to be watching, and we've asked them to innovate. We've taken 3 or 4 new initiatives to them just in the past couple of months, and they've been tentatively enthusiastic. It's more about how you administer these things, how you pay claims when we expand benefits or add extra services. So we're certainly committed to doing that, and the new Medicaid contract will start, interestingly, January 1st, 2017. So the bid is out, the RFP has already gone out, and we're going to see what the submissions will be from the MCOs. We fully anticipate there will be many new players coming into the marketplace that would like to participate, because they know how cutting edge Indiana is, and it's an important thing for their portfolio to show that they can function well in a state like Indiana. So we're going to look at the very best and innovative programs that any of these MCOs are bringing forward.
Wonderful. We often hear that a rising tide lifts all ships, and it's tough when you're an agency head, because you're the agency head for the entire state, not one specific area. But we also know that a rising tide doesn't lift all ships if there's a hole in one person's boat. So what are you doing from an FSSA point of view? And again, back to the MCOs, are you doing anything specifically to ask them to address health disparities? Again, whether it's urban and rural, whether it's economic status, whether it's by race, whether it's by ethnicity.
Well, again, the data that the department that you're generating out of ISDH is crucial in that. If you don't, and you've heard other speakers say it this morning, if you don't know the disparity exists, you can't really address it. And I think in the past, we have a general idea that these disparities exist, but where specifically? And we've seen this on the mental health side in Scott County and other areas. We've got holes throughout the state that potentially could bloom into major public health issues because we don't really have a good handle on the data. So we see the MCOs as our partners in this, and we hope that you find them to be good partners. Many of them are here, and I think would emphasize their desire to be good partners with the providers. But I think you said the word, Jerome. It's really how quickly we can innovate and pivot and change, rather than saying this is a concretized health plan and we're only going to do these things and only going to cover these services. So I think there's really a spirit of change going on, but it's in the flexibility of saying once we have the data and know where the problem is, then really get almost the SWAT team approach that the health plans will commit resources to going into those areas and figuring out what really works, because again, what works in one part of the state doesn't necessarily work in other parts of the state. And so we have to be more reflective, no different than individualized medicine. We don't say the same antihypertensive works for every patient. In this situation, we don't know what works in every county, but we can get a pretty good idea from best practices and models elsewhere in the state. So again, it's really more of a philosophical change rather than just saying we have these specific plans you need to institute.
Well, one of the untapped resources, I think, in our state are our tremendous schools. So we've got schools of nursing, we've got schools of medicine, we've got schools of public health, but unfortunately there seems to be the silo system seems to have taken over, and we're not tapping into that resource. You're a teacher at the School of Medicine in addition to being the head of FSSA. How can we better utilize the tremendous assets that we have in our state in the form of our academic centers that are really spread throughout the state, whether it's Notre Dame up north, whether it's Purdue, whether it's IU down south, whether it's Terre Haute. How can we better leverage that capability to improve the health of people within Indiana, and particularly to lower our infant mortality rates?
I think the governor has shown great leadership in this area. It's the expectation from all these schools that are receiving some type of state support and state funding that we begin to start working as learning cooperatives. There's no reason to duplicate or triplicate some of these research areas, and starting to get the schools to work together. Unfortunately, with the way we fund, particularly medical education, but health science education across the board, that has become a real barrier, and it's problematic when you try to get everyone to get on the same page and work together. And we certainly, the governor has formed a task force looking at health providers and where we need access to more providers. This is a national initiative, but once we start drilling down here on a more local level, we're going to be able to leverage many of these educational resources that we have and start using our schools more appropriately. They do help us on specific projects, but you make a great point. Where do you pull all that together and getting them all around the table to say, you know, who's doing the best job in this particular area of health outcomes research, and we need to be very focused on that. So again, it's nice to have that financial lever, and I don't think in the past many people have put a hand on that lever. I'd like to get the hand on the lever and start to crank down on the schools to get them to not only just address helping us with workforce issues, but really helping us change this whole philosophical approach to healthcare and consumption of healthcare, as I was outlining in my speech. So I think consumer-driven plans, we don't teach our healthcare providers much about the business side of medicine. We also don't teach them much about addictions. We don't teach them much about appropriate prescribing of certain medications. So we have a long way to go, and much of this is driven.
And that's a place where the academic centers can help get involved and help us teach them earlier.
But if they're all getting their accreditation from national bodies, you also have to change the hearts and minds of people at the federal level. And I think that's starting to occur as well. Unfortunately, it always happens in reaction to a crisis rather than in a thoughtful way, proactively. So
great. Well, thanks so much. Wonderful conversation.
Thank you, Jerome.